Hi, I'm Tanya Antony, and I'm currently pursuing a master's in psychology from St. Xavier's College, Mumbai. I'm also an extern with Rochester Institute of Technology's Priority Behavioral Health Program. Today, I'm presenting my poster on the title Strength-Based Interventions for Intimate Partner Violence Using Digital Screening Tools. Intimate partner violence, or IPV, refers to any behavior engaged in with the goal of inflicting physical harm on one's romantic partner who desires to avoid such harm. According to the WHO, over 1 in 4 women between 15 to 49 years who have been in a relationship have experienced physical and/or sexual violence perpetrated by their intimate partner. Research on the prevalence of IPV among the homeless population is limited, and more so in the Indian context. However, studies in other countries do highlight the seriousness of the problem of IPV among the homeless. With regards to the population as the homeless shelter where this intervention will first be implemented, 63% of the clients are female and 31% have reported history of family violence. For example, people have reported their in-laws trying to burn them or physically abuse them, and 42% have reported experiencing family conflict. The stigma around domestic violence and the tight-knit nature of the family as rooted in the collective makes intimate partner violence especially sensitive in the Indian context, and Pillay has referred to it as a crime of silence, and this further stunts the development of necessary interventions. Therefore, the aim of the present study is to develop a strength-based intervention for survivors of intimate partner violence. Approximately 75 survivors of IPV will participate in the strength-based intervention, and participation will be in the form of 10 to 12 one-hour sessions per week. Homeless survivors will be recruited from a homeless shelter in Mumbai, India, and participants will complete the digital screening related to IPV and engage in strength-based cognitive behavioral therapy. The source of material used to gather data include PHQ-9, GAD-7, DSM cross-cutting, PCL-15, MMSE, intake forms assessing pre- and post-distress levels, and progress notes. Coming to the digital screening tools, using digital tools for the detection of IPV has been proven to elicit higher rates of IPV detection as compared to interviews due to the sensitive and taboo nature of this topic. Greater detection is also associated with improved frequency of chances to talk about IPV and the detection of women at risk. The conversation around IPV is accompanied with improved rates of discussion about mental health disorders that may be linked to IPV victimization. And the non-judgmental and anonymous nature of computerized tools encourages disclosure, as does the absence of the need to explain responses in such a situation. There have been certain barriers that are identified in terms of screening for IPV, and these include patient-related barriers, lack of resources, fears of healthcare providers, personal barriers, and attitudes and perceptions about the roles of healthcare providers, as well as the abuse experience itself. Some common themes that are prevalent in the assessment for IPV as identified by HACE include relationship context, forms of abuse, imminent risk indicators, family dynamics, the degree of support, and assessment structure and psychometric information. These are all certain themes which our screening tool will also address as part of the screening process. Interventions designed for survivors of IPV have been developed with various goals in mind, with some catering to empowerment and advocacy and others to well-being and mental health. Contrary to the disease model that traditional psychotherapeutic interventions adopt, strength-based therapies take an alternative approach such that they focus on the positives and the capacities and resources of the individuals that can be drawn on to deal with the concerns they face. The experience of harm inflicted by a trusted person has a range of psychological implications beyond the physical distress that it causes, and the survivor of IPV may lose a sense of who they are and their belief in their capacities, and the accompanying emotional abuse in such relationships results in reduced self-esteem and diminished identity. The stigmatization of IPV and the silence around it in the Indian context leads to a lot of internalized shame and guilt among survivors, making a strength-based intervention especially crucial in empowering them. These implications point to the need for a strength-based approach in working with survivors so as to facilitate a recognition of each individual survivor's strength and use them to build resilience in the face of trauma and enhance coping skills. The present study is grounded on the framework of strength-based CBT proposed by Podesky and Mooney. Given the cognitive, emotional, and behavioral implications of IPV, a cognitive behavioral approach that addresses maladaptive thoughts and negative appraisals of events in one's life and the behaviors it sustains can be especially useful in treating survivors. Moving beyond the mainstream of treatment change, Podesky and Mooney's model focuses on building positive qualities and constructing a personal model of resilience to cope with life's challenges. The model is adapted to be suited to the population of homeless survivors of IPV in the Indian context, and the alterations in the present study include psychoeducation about IPV and trauma and the implications it can have for the survivors, inclusion of nonverbal tools for the psychoeducation, identifying some positive relationships that are currently existing in their lives to facilitate resilience and empowerment, and to reframe cultural beliefs surrounding victimization to cope with shame and guilt. The strength-based model developed by Podesky and Mooney is deemed appropriate for working with this population for various reasons, as one of them being that the autonomy and agency given to the clients throughout the process of therapy can facilitate developing an enhanced sense of self-efficacy and self-esteem, which could have been diminished due to the nature of the abusive relationship. Considering that the intervention is being developed for the homeless population, the individuals will also face a range of challenges, and developing a personal model of resilience that is unique to them will provide the client with the mechanisms to develop their intrinsic strengths to solve their problems in the present. The current intervention aims to cater to individuals with limited verbal and cognitive skills through the inclusion of nonverbal material. Existing research has indicated the efficacy of nonverbal modalities in the treatment of clients with psychosis, verbal limitations, and other associated conditions. It is expected that survivors will be able to identify their strengths and build resilience in their current context and work through the guilt and shame they may be experienced due to the stigma of victimization. In the current study, the Indian cultural context will be very closely attended to, as how the survivors' empowerment might be received by their family and social circle will influence the process of empowering them and the outcome in terms of what empowerment would look like. Thank you. And if you have any questions, please feel free to reach out to me at my email address, which I have mentioned in the poster.